How do you evaluate and manage diarrhea in patients with colorectal cancer who are receiving immune checkpoint inhibitors? As we know, diarrhea is one of several potential immune-mediated adverse events that can be caused by immunotherapy. When you're treating a patient with immunotherapy who has colorectal cancer and they develop diarrhea, it's very important to rule out other potential causes for diarrhea before you jump to the conclusion that they are experiencing immune-mediated colitis. One item to rule out is short bowel syndrome. Many of our patients with colorectal cancer have undergone pretty extensive bowel resections and are left with shortened bowels that can interfere with absorption, and therefore they experience lifelong diarrhea after their surgery. That's why you need to ask your patient at baseline about their bowel habits and stool patterns and know if they have baseline diarrhea. And if they do, watch for any change while they're on immunotherapy. Another item to rule out when evaluating these patients with diarrhea would be C. diff. Many of these patients are in and out of hospitals for imaging, other illnesses, so on and so forth, and they can potentially be exposed to C. diff and contract it themselves. Also, we know antibiotics can be a potential cause for C. diff as well, and these patients are oftentimes treated with antibiotics for other issues, whether or not related to their cancer. So rule out C. diff by ordering a stool culture on these patients as well. Also, ask them about their home life. Are other family members experiencing diarrhea? If that's the case, it could be gastroenteritis or food poisoning, something more infectious instead of an immune event. If you have ruled out every potential cause for diarrhea that you could possibly think of, you may want to consider referring the patient to gastroenterology. However, if you don't have time to do that, the patient's experiencing diarrhea, you're fairly certain that it is an immune event, you do not want to delay intervention by any means. So you will need to start the patient on steroids. That's the first line of treatment for immune-mediated colitis. The recommended dose is prednisone 1 to 2 milligrams per kilogram per day, or the equivalent. And after you start your patient on high-dose steroids, you will need to watch and observe and talk to your patient routinely about any improvement in diarrhea. Get them back into the office for follow-up or call them by phone to make sure they are responding to steroids. Now, one thing to keep in mind in a patient with colitis is that you may need to utilize IV steroids for the first several days, because with the pre-existing diarrhea, the patient is not going to absorb oral steroids as well. So you may need to utilize IV steroids and then transition them to oral steroids appropriately. But talk to your patient after starting them on steroids, make sure they're responding to steroids. And in the very rare event that the patient is not responding to steroids, you will need to use anti-rejection drugs, such as infliximab or mycophenolate. It's very rare that a colitis is not responsive to steroids, but yes, it does happen. So know that there are other tools in the box that you can utilize if the patient has not responded to steroids. Now, of course, while the patient is being treated for immune-mediated colitis, you are going to hold their immunotherapy during that time. Once their colitis or their diarrhea has improved to baseline or to grade 1, they've completed the steroid taper, and you've noted a remarkable improvement, you can possibly consider re-challenging the patient with immunotherapy in some circumstances. However, there are certain grounds for discontinuation of immune therapy. For instance, if they develop a severe diarrhea a second time while on single agent immunotherapy, or if they develop a grade 3 or a severe colitis while on any combination immunotherapy.